Welcome to Dr. Diaries. I'm Hanya Oversby, and today I have, it's my absolute pleasure to speak to Associate Professor Greg Goodman. I've known Greg for many, many years, and he's very, very highly regarded in the industry. Greg has been a practicing dermatologist for more than 20 years, and his areas of specialty include skin cancers, Mohs micrographic surgery, lasers in dermatology, cosmetic dermatology, and the treatment of acne and post-acne scarring. He holds the position of Chief of Surgery at the Skin Health Institute and has an academic teaching position as the Adjunct Associate Professor with Monash University. He's a national trainer for numerous temporary dermal fillers and a member of the several international editorial boards and advisory committees. He's always had a keen interest in skin cancer, skin care, skin muscle relaxant injections, dermal fillers and lasers. That's his dog, Rufus. Welcome, Rufus, to the podcast. So, Greg, welcome. That was a perfect segue. I'd like to thank Rufus for that. Thank you for joining us at Dr. Diaries.
Thank you. Okay, well, since that bio, I suppose a couple of things that I should add in. I suppose I'm now also an Associate Professor at University College of London, and I'm Chief of Task Force for Higher Education Provision in Cosmetic Dermatology at the Australasian College of Dermatologists for provision of graduate certificates, graduate diplomas, masters in cosmetic dermatology to postgraduate dermatologists. So I've got a strong interest, obviously, currently in cosmetic dermatology, which I think might provide a focus for this little podcast in times of COVID-19, which I'd like to discuss down the track, but there you go.
Yes, absolutely. Look, I think it's very, very interesting times, Greg. It's, as I sort of mentioned earlier, I've known you for many, many years, and medicine has been operating in a particular way for a long, long time. There was we sort of had dermatology, and then there was a change and a focus onto cosmetic dermatology, which you really have been the champion about. Maybe you can take us from medical dermatology to cosmetic dermatology, maybe the journey up until recently. Yeah.
Look, I did have one of those epiphany moments, and it related when I was doing my let's go back a step. When I was finishing medical school, I was fated to become a gynecologist and actually started studying for the first part gynecology, decided that wasn't for me, then studied for the first part surgery, decided that wasn't for me, then started studying physician training. And I was doing cardiology as a JRMO with...
Oh, hang on a second, Greg. Sorry, I just missed that.
Intensive.
Hang on a second, Greg. I just missed a bit of connection issue there. So you were doing the cardiology, you were saying?
I was doing cardiology as a prelim to presumably going to try to end up being a cardiologist. And it wasn't a time when dermatology was purely an outpatient specialty virtually. And so they had a heavy load of cardiology, and they figured they need to offset it against something lighter. So at the time with cardiology, we were doing the first stent in Australia in the unit that I was in. And it was a very exciting time, and everybody was really on tenterhooks, and it was really had all the cardiothoracic unit on standby in case the whole thing went pear-shaped, and I worked up the patient, and it was really quite an exciting time. And at the same time, I was doing dermatology outpatients, and which I didn't think too much about. I just walked into dermatology outpatients and saw the patients, walked out of dermatology. I never really thought too much about it. And came the end of this stint, which went very well. You get this, is this as good as it gets? And it was as good as it was ever going to get. And it just didn't quite do it for me. So there I was thinking, how many ologies can I try before I work out what I want to do? And I was walking out of dermatology outpatients on the last day, and Nick Downs, who's a very nice dermatologist who has, I think, just retired, turns around to me and he says, have you ever thought about doing dermatology? You'd be a really good dermatologist, I reckon. And that was just one of those moments where he hit me right between the eyes at the time I was most vulnerable. And I said, oh, okay, that's something I could possibly do. And the rest, as I say, is history. And as far as the cosmetic aspects of dermatology, it was also an epiphany moment when I was literally saying to myself, oh, look, it's really busy doing the second part dermatology exams. There was an overseas guy called John Yarber who was coming out to talk about dermabrasion, which he'd popularised and was a master at. And I thought, shall I go to this lecture? Shall I not go to this lecture? And anyway, I ended up going to that lecture, and that lecture changed my life again. So John Yarber was a very elegant southerner of New Orleans and had 2 grand pianos in his entrance hall. It was quite an entrance hall.
Wow. Is that at his practice or at his home?
No, that was at home. So he was a concert pianist as well as being a dermabrasion expert. So, I got quite friendly with John, spent some time with him post-grad, and I said to him, look, I really think I want to become a cosmetic dermatologist. And there was no cosmetic dermatologist back then. It was it was in the States, but not in Australia. And he said, don't do it. He said, just maintain your core discipline, never give up your core discipline. And that was at a time when a lot of my compatriots in America were giving up their routine dermatology and their surgical dermatologists to become purely hair transplanters or cosmetic dermatologists or whatever. And he advised me against it, and I had such respect for the man that's exactly what I did. I never gave up my core dermatology, never gave up. I went and did Mohs, micrographic surgery, as a 2-year fellowship in the early 90s, a few years after I graduated. And so I extended that and brought Mohs to Victoria. I never gave up the full gamut of dermatology. I've always had a keen interest. And my keen interest is not so much in kind of facial rejuvenation-ish sort of stuff. It's always at the edge of medical, surgical, and cosmetics. So I did a PhD in acne scarring, and I really, that's my area. My area is really on where cosmetic meets medical dermatology. So that, in a nutshell, is my little personal journey, I suppose.
Yeah, and I think just that's the role you've played in bringing those two worlds together has been pivotal from that perspective that you have from the science of it, brought the medical dermatology and the cosmetic dermatology together.
Yeah.
So
they can't really be separated. I think that dermatology is a visual science, and it's an aesthetic science. It's a science about making the skin the best it can possibly be, the healthiest it can possibly be. And anybody that believes that we don't all dabble in the cosmetics part of medicine.
Oh, hang on a second, Greg. Just a bit of a connection issue.
Really,
so the cosmetic medicine,
properly. Okay.
Yeah.
Yeah, I think anybody that doesn't dabble it doesn't feel that the cosmetic elements weigh into their day-to-day looking at patients from a dermatology point of view is really deluding themselves to some degree. We all worry about the aesthetics of the patient. That's what the patients are commonly seeing us about. It's not about itch or pain in their skin. It's about what they look like.
Yeah. So just through, I agree. And through your journey, you would have had a lot of colleagues years and years ago that may have looked at you askance, saying, Greg, what are you doing? You're going to the, cosmetic side. How did you marry the two worlds up here in Australia and bring them on the journey with you?
I don't usually go to clinical meetings like the general dermatology clinical meetings anymore because life has just become a little bit busy. But about 10, 15 years ago, I used to go to every clinical meeting, bring a patient with me and show the general dermatologist how the tools of cosmetic dermatology can be used for a patient with a general dermatological issue. So I would show them fine wire diathermy for milia. I would show them how to treat syringomas around the eyes. I would show them how to treat xanthelasma. I would show them how to treat how to treat for wine stains, but basically the stuff that they would consider, and acne scarring obviously, that they would consider reasonable things to treat in any world, and show them the tools that we have to use. For example, fillers for acne scarring, for an example. So the tools we have to use that we wouldn't have if it wasn't for the cosmetic parts of our industry, and how we can bring to bear to treat patients that they would consider very worthwhile patients to treat. So I did that. I did that literally for about 2 years. I showed them how to. Anyway, I won't go through all the stuff that we discussed, but so I tried to bring it to the rank and file dermatologist. The other thing, the reason I mentioned the University College of London and the higher education division in the Australian College of Dermatologists is not really to big note myself. It's actually to showcase the fact that these organisations, the University College of London, my appointment there is purely to curriculum developed for cosmetic dermatology. That's all it is. And for the higher education division at the Australian College of Dermatologists, it is purely about providing higher education in the area and making the college understand that there is a requirement to be specifically trained in this. And we're trained to some extent through dermatology anyway. We have to examine on, fillers and botulinum toxin and lasers and all the rest of it. So you have to have some modicum of understanding when you leave. But there's always more you can learn, and therefore that's what those fellowships are all about. So it's a matter of just bringing my colleagues slowly into the realm, and I've always pushed very hard to have the annual college meeting of dermatologists to have some component of cosmetic dermatology in there. When that became a little bit harder at some stage, that led to the development of the Australasian Society of Cosmetic Dermatologists, the ASCD, which was formed in 2013. And its advancement since then has been an outbreak from the initial offerings that were being done for those college meetings, and it's become a force of its own, obviously, with about 160 dermatologists as members or as affiliates, and roughly 600 odd people coming to the conference until obviously COVID-19 has gotten away.
Yeah. Yes, here we are, that COVID-19. Just sorry about that, Bing. There was a text that came through. Yes, well, I suppose that's an excellent segue to what has happened. So maybe you can take us through your journey. I mean, we're all happily in March, early March, plodding along, looking at what's happening around the world with COVID. And I don't know about you, but here in Australia, I always feel like we say, oh yeah, that's happening over there. It's probably not going to happen the same over here, but it was a different story. So maybe you could tell us your COVID journey.
Okay, well, it shows how ignorant you can be at the beginning, doesn't it? I thought, COVID-19, so people are going to be staying at home a fair bit more. They could probably have a whole lot of procedures done where they can just stay at home and recover. And I thought, this isn't going to be so bad. Patients been mounting up all this stuff. They never have any time to do anything. Now they're going to have time to do something. And so early March, maybe late February, early March, patients were coming in and saying, "Oh, this is a real good thing, and I can work from home, and I can have my laser resurfacing done, and I can have my my big treatments done, and that sort of thing, my blepharoplasty, my whatever." So they can. So I was thinking, yeah, what a great idea. It didn't take long to realise that was a fairly fanciful concept, and so when lockdown happened right at the end of March. 25th of March, whatever it was, and the level 3 restrictions came in, we suddenly realised this is pretty serious, and so everybody, like we and everybody else, down tools, and we've been clawing for a way out ever since. It certainly affected my practice, like everybody else's practice. Initially, certainly it meant the rise of telehealth, and like everybody else has done, it's been an energising medium. I like it. It's fun. The patients like it. They don't have to sit in the waiting room, kind of wondering what to do for the half hour and getting really annoyed that they've got to be at work and that sort of thing. So they're at home. At the moment, it's probably an artificial environment, but they're at home. they're actually quite happy to have somebody else to talk to.
It's true. It's true.
And so they almost look forward to it. I've never had so many kind of happy patients in a consultation. It's quite an unusual environment. Not that they're not happy when they see me, but they've kind of got this almost this joie de vivre over the line that they're really quite excited.
I agree.
I think dermatology is such a visual field that, except for things like skin cancers and skin checks and that sort of stuff, you can't really do that for telehealth, I don't think, at all. But the rashes and things like that, within limitations, you can normally diagnose stuff pretty well. And what it forces you to do a little bit, which is interesting, is we normally rely a lot on examination. We rely on just looking at something as a dermatologist in the first 30. Old saying that late Harvey Rothstein used to say, if you haven't made the diagnosis in the first 30 seconds, you're unlikely to make it 2 years later. Because if you looked at somebody and you haven't made the diagnosis, it's unlikely you're going to make it with all the ancillary tests you make. So it's just back to life with dermatology. But what it is with the fairly poor quality of telehealth imagery, and the fact that it's a two-dimensional image on a three-dimensional face, you have to rely a little bit more on history. So I have to actually listen to the patients a bit more and actually kind of take what they're saying in more literally than I would have face-to-face, where I can see what I'm dealing with a bit more. But normally the marriage between the two, the marriage between the history and the examination on telehealth, I think is as good as what I would do in the surgery. No better, but it's certainly as good. And it's obviously safer in today's environment. Cosmetically, I think you might be able to plan cosmetic treatments. We haven't really used it that much for that, but we're kind of thinking it might be a good idea. But certainly for follow-up, it's a much better way to follow up. I mean, there's no reason that you need to have a patient, unless you want to get photos and stuff, but there's no reason to have a patient, come to you 4 weeks post-botulinum toxin or fillers or whatever, except to have a look at your own work and critique your own work and to make sure the patient's happy. I think you can do that on telehealth pretty well. So I think the pre and the post could be where this leads to in cosmetic aspects of the profession. Obviously, you probably can't inject or treat through telehealth, but you certainly can do the preamble and get the COVID stuff right, get the questionnaires right, get their responsibilities right, make sure the patient understands that when they come into a practice, they're going to have the temperature check, they're going to have their social distancing, they're going to have the decreased flow, they may have to sit in their car if the practice has got an overload of patients, that you institute all the things you have to do. But realistically, most of the things that we do are fairly low risk procedures as far as COVID goes. And as long as the patient is truthful with their COVID answers and we are strict with our social distancing or physical distancing, I think we will come out of this in a fairly safe way and we'll proceed in a fairly safe way down the track.
Yeah, I agree with you, Greg. And I totally agree with you in that telehealth's opened up a whole new avenue of patients to interact with you, the doctors and the dermatologists. So you and I were just speaking a bit earlier, but I feel that there is an opportunity for time-poor patients who may interact with you or your practice. They would have liked to previously, but didn't have the time to make the appointment, sit down with somebody, investigate the options, talk to you about their concerns. It's that opportunity now, I think, which is quite exciting because nobody has to leave their office. You can actually block it in your own appointment book just as much as the dermatologist does. And what's so great with a lot of software is you receive a text now saying your doctor's ready, press the thing and off you go. How are you finding that's working? Well, look, a lot of these are not very reliable, unfortunately. I wish they were more reliable, but they're just not that reliable, the actual systems. Sometimes they work and sometimes they don't.
And often I'll just have to mix between the two, like between the offerings. We've tried all the major platforms, and sometimes I work beautifully, and then sometimes I fall over and I go back to WhatsApp or FaceTime, and I have just every so often it doesn't quite make it, but look, they'll only improve. The thing that has happened is the government tried, as you may remember, about 4 years ago, maybe 5 years ago, to bring in telehealth, and they gave great incentives for initial telehealth to be utilised, and then didn't follow through with item numbers that are appropriate, didn't follow through with the push through that they needed, there weren't great platforms to do this on. And they refused to do things like store and forward with photos, and they wouldn't allow that, and they put a lot of impediments for patient privacy stuff in the way. They still do. I mean, we should be on email. It's just ridiculous. We can't. In today's, they think a fax is somehow safer than an email. I don't get that. I have no understanding of that. And faxes have gone out, I think, with maybe with high button boots, and anyway, there might be back in high button boots.
I know. It's very rare. There are some practices, but yes.
So we have a fax to send to the chemist for the patient. So there's a long circuitous route. So we have to actually take the phone number, or take where they go to the chemist. Look up the chemist's website, then ring up the chemist, then get the chemist's fax number, then fax it across, then snail mail the actual script back. I mean, all this is all pretty cumbersome. So that'll all have to change. But the fact that the government has been pulled into telehealth in this current environment has given an infrastructure in a great hurry that will stay. And telehealth will be a permanent part of all dermatologist practices, and I would imagine become a permanent part of all cosmetic physicians' practices as well. It's just it's perfect for not perfect for the pre-selection of patients and the planning of patients, but it's okay. But it is pretty much perfect for looking after patients after they've had their procedures, I think.
Yeah, I agree. And there's different points of the patient's involvement at the practice and with the dermatologist that you could definitely make use of telehealth. And look, eScripts, many practice management softwares have got that happening, and we talked about the video consults and those sorts of things, to the point I feel I've heard patients say, I'm actually only going to do telehealth from now on. So say, for example, interactions with GPs, people who need scripts, people who just need a certificate, they're not going to want to go in to any doctor's practice ever again. In fact, your business is going to have to pivot a bit to say, well, we need to accommodate for this type of patient who wants that convenience not to have to come and see a dermatologist or a GP or whatever ologist, as you said, if they can avoid it. It's very interesting.
Look, there's no reason, for a repeat script, for example. Patients ring up the practice, I suppose, and ask for a repeat script, so we send it off. But there's no reason that they shouldn't just have a short telehealth thing to make sure that it's appropriate, and and do it that way. So basically, you don't have to have a situation where you're just blindly giving somebody a repeat script because they've run out. You've got the chance actually to review them properly without inconveniencing them very much. The only thing I say about telehealth is it is quite time consuming, much more so than you think it's going to be. By the time you actually get them online, by the time you actually do the thing, and then you do the post stuff afterwards, it is a little bit more time consuming than it should be, and it could be smoothed out, I think. So the pre and the post, the actual talking to, I think is fun. I'm liking it, the patient's liking it. I don't think that takes more time, but the actual pre and post stuff is much more work for the practice at the moment than it probably should be.
Yeah, I think over time people will be able to sort of streamline that. The other thing to think about is the level of reach of patients that can access you. So what I think is exciting is, say, rural patients, interstate patients, rather than marketing to patients within 100 kilometres of your practice. You now can actually see patients all around Australia. And as a dermatologist, you're a your unique value proposition is very high. There's only so many of you. That means you can't go to rural areas, or there's some areas in the Northern Territory or WA, north of wherever, that don't have access to. But now, and if you market it properly, or is this an opportunity for your business? Is there something that people can have access to specialists they never could before? So what are your thoughts on that?
Yes, we've looked at that. I'm looking at that quite seriously. I think, we've always had a problem with rural dermatology. And look, I remember, I'm old enough to remember when you only had state licensing in Australia. And so you could only actually practice in Victoria if you're a Victorian doctor. And if you went into state, you had to go to the medical board in that state and had to make your case and make a submission for you to be able to actually speak or see a patient in New South Wales or Queensland or whatever. And also that if you did a telehealth, if you did a consultation that was maybe over the border in Albury or something, that you would actually not be insured for that telehealth consultation. So insurance was also state-based, and it was a real problematic time. And people were trying. I know there's a guy in Queensland who's been telehealthing for 100 years, dermatologist up there, very, very able, and has been pushing governments, when this was operative, to stop being so stupid. And eventually the APRA got invented, and now we're able to practice throughout Australia. And we have insurance status to give opinions on telehealth, and that was not automatic either. That had to be fought for, because although you could give opinions, you were actually legally responsible for those opinions. And if somebody took you to task saying, "Oh, you couldn't have possibly made that diagnosis by telehealth, and you shouldn't have done that, and you should have," then it was a problem. So I think everybody's growing up, especially COVID has made it grow up a bit faster. So understanding the history of telehealth makes you understand that its shortcomings to some degree and how they're slowly being overcome. And there still are some shortcomings. Part of what we're seeing is the software that's not quite perfect yet. But and the requirement that you do need to see photos, high quality photos sometimes. You can't just rely on the grainy videos you might be seeing on WhatsApp. So for ages, the government was not that willing to support store and forward, and we do need that. So there are some obstacles still to be ironed out a little bit, but it's a great medium, and it will only continue. And I think this is the beginning. Whether we post-COVID rely on it quite as much as we will for the next 12 months, it's debatable. I think most patients prefer face-to-face, as long as they're not regionally based. It'd be crazy to travel 2 or 3 hours to see a dermatologist if you can make a phone call and see them in the same sort of way. We're a bit cheaper for telehealth than we are for consultations in-house, because it's less hassle for us and less requirement on staff. But still, I wouldn't be amazed if we revert back a little bit towards face-to-face rather than virtual.
Oh, I agree. There's especially in dermatology, people want the dermatologist to have a look, or you want to, when you do have your treatments, to see what the outcomes are, what the next steps are. I totally agree. I think though it'd be interesting at this point to say, with a lot of my practices, we're doing a business reset, re-looking at your business. Do we need to pivot around? How a business is going to look like moving forward? And a lot of that involves looking at where we've come from, measuring what has happened in terms from where we measure. Sorry, I'll scrap that. So a lot of that involves looking at where we were pre-COVID, how our businesses were operating, but then measuring, collecting a lot of data and saying, how was our business operating before? And then taking all that and saying, how can we do things differently moving forward? So for example, like you're saying, telehealth is a lower return to the practice. But there is an opportunity by introducing telehealth to make yourself more scalable. And interestingly, you could be more scalable without actually even having to grow your practice physically, but having doctors working from their own homes, as you have been, but under your brand, Dermatology Institute of Victoria. So, and you could create and use your infrastructure to help them out. There's many ways that I think
yes,
practices are going to change.
We are planning exactly that, actually. So yeah, we've definitely thought of that. And, you know, to some extent you have to, because while COVID's around and the physical distancing is required and the decreased flow is required, it's meant to completely restructure. It's meant a restructure of our practice. For example, we used to love days where there were 2, 3, even 4 dermatologists working at the same time, because we could be collegiate, we could actually be giving second opinions to each other, we could be bringing people in to see interesting cases and give an opinion on that. We just can't do that anymore, because it means that the patient flow is too strong, and you know, it won't work with the 25% rule. It won't work with social distancing, and so we've had to reorientate our entire week to make sure that we just do not interact. The dermatologist, I might work doing consults in an afternoon, and maybe Catherine might work in the morning, and Lee May might work the next day, and Margaret, Sarah, and Nina. So we have to restructure our people. At the moment, we haven't even got our cosmetic injectable people working. So when they come back in, we're going to structure them so they don't actually have high patient flows. Plus, we're actually fellowing rooms. So we're actually, when we're using a room for anything, a procedure room for anything, we actually scrub that out, and then we leave that room for as long as we use that room. That's our rule. And so it means that our procedure rooms have to be staggered in such a way that there's enough time between patients, so that we actually know that we've actually sterilised the rooms properly. So there's a lot of rethinking has to go on. I used to have blocks of procedures, blocks of consults, which I love because it means you're much more efficient. I can't do that anymore. Now I've got to have procedures and consultations intermingled. You know, I can't do a block of skin cancer procedures, for example, because I use the same room. So I have to actually do exactly the opposite of what I've been working on for so many years. And that means changes in staffing. And the staffing were done in such a way that we had different staffing for consults than we did for procedures. So it is a matter of adjustment. And when cosmetic injectables go back in Victoria, which isn't quite yet, you know, we'll have to again factor all that in too. So yes, there's a lot to think about, and we may never get back to where we were. It's possible, and we may require things like the telehealth to supplement that.
Yeah. Absolutely. What about your energy-based devices? How are you putting them in the mix? And are you allowed to use them yet?
Well, we're using them for any medical things. So basically, if we're needing them for PDT for skin cancers or for pore wine stains, things like that, or some with inflammatory acne for some of the light-based devices, we're using that. But we've got a severely limited, so there's no, we're not treating melasma with devices at the moment. We're not treating rejuvenation things. So we're just not doing not doing very much at all compared to what we used to.
It comes really down to the rooms, isn't it? It's the space now.
It's the space, and also it's the space, and also it's what produces things like plume, for example. Like, I can't see myself going back to doing fully ablative erbium laser on a big area for a long time, probably not until COVID is over, because of the plume that's generated. And we don't know the behaviour of COVID and plume. It probably doesn't exist in plume, but still we just don't know that. And unless you've got your HEPA filters and your high volume extractors and all the rest of it, it's problematic probably. And the same probably with certain types of ablative fractional CO2. If you've got a luminous device, the ultrapulse, the active effects is quite plume creating as well. So anything that's extremely plume creating, we're staying away from into the near and medium future at least.
Yeah, that's very interesting. Very interesting. So with I think we've now with announcements and your sort of things are slowly going to be opening up. Are you looking into the next 12 months, 18 months with your hands ringing from nervousness, or are you feeling, oh, this is exciting, we've got new opportunities available to us? What's your sense in terms of your practice and where we're going in the sort of short term?
Look, I think it's more hand-wringing. I don't think there's a lot to be optimistic about. I mean, yes, the advent of telehealth is interesting and worthwhile, but would I prefer February 2020 to what's going to be August 2020? No doubt I prefer February. I think that it's going to change our lives a lot, and I don't think turnover-wise, revenue-wise, practice-wise, it's going to be quite the same. And you also got to factor in that people are going to be poorer coming out of this. Their discretionary income will be significantly less, and we're going to go through a downturn. However, if you ask me about 12 months from now, then I think it's fantastic. We're going to have a resurgence like I reckon you've never seen before. I reckon next year, although it'll go down 10, 12, 15% GDP this year, I reckon if you're not an eternal pessimist, you've got to expect a rebound of 6-8% next year, which will be an extraordinary time to live in. People will be almost celebrating. If we get out of COVID, there's going to be a celebratory, going to be an excitement in the atmosphere that will do all the gloom will be like a past event. So if they find a vaccine, find a treatment, whatever, it doesn't have to be a vaccine, obviously, it just needs to be something to keep people off the incubators. Then I think the level of palpable relief in the community will lead to an enormous economic upturn.
Yeah, I agree with you. And people are looking to that. They want to have their old lives back. And especially in the area of aesthetics, it's definitely somewhere that everybody's going to want to turn to to feel better about themselves, what's happening around them. So yeah, I totally agree with you on that point, definitely.
Yeah, I think that the feeling that we always suffer in aesthetics from, and you asked the question about my peers, we always suffer from this inferiority complex about what we do. But realistically, I mean, beauty is such an intrinsically, it's a beast that people need to want to aspire to. It is something basically caveman orientated. It is a basic belief in us, and that you should be as good as you can possibly be. And there's nothing more uplifting than people actually going through a time where they can suddenly start looking at themselves and saying, I want to be as good at Hanya Oversby as I could possibly be, or I want to be as good at Greg Goodman as I can possibly be. It's a rare person who says, no, I'm willing to accept that I'm really crappy now, and then I'm happy to live with COVID-19. I'm happy to live with being stuffed up in isolation and not washing my hair for 6 weeks. It's unlikely that's going to continue. People are going to want to look as good as they can possibly be. It's an intrinsic human wish, really. That's why they kept the hairdressers going.
Yes,
I guess.
Absolutely. And I totally agree with you. In fact, I suppose the key message then is just to keep your business going, keep your practices going. And it almost feels like it's going to be one of those slingshots where something's like being pulled back. And then once you're saying at that 12-month mark when there'll be just this big catapult, I think, of the business is growing.
I also think there'll be a mini surge, which I would caution people to get too excited about. I think once the restrictions are lifted, and that's going to be a state-by-state thing, I guess. But when the cosmetic restrictions are lifted, there will be a rebound, and obviously the people that you would normally be looking after are going to want treatments, but there might also be a bit of rebound in people that want to feel good about themselves. I would caution people a number of things. One, that is probably going to be a temporary rebound. and it will be an artificial one, and I suspect towards the end of this year there'll be quite a dip. So don't necessarily starve yourself as though the rebound's going to stay forever. And don't be tempted to crowd people in because they're asking you to. Be COVID safe. Make sure you space the patients. Make sure you space the treatments. Because last thing you want is a blip, obviously, and coming out of a cosmetic practice would be a disaster. And those people, if you look after them properly and they see that you're looking after them in a safe environment, then that rise that inevitably will come might sustain itself better than if we do the opposite and treat them willy-billy, and then we have a problem, or you end up having patients thinking that they're being overcrowded and being overserviced. So just play it gently, I think, in the first when the restrictions are lifted.
Yeah, good advice, Greg. I think that's very very good advice. Just look out for the longer term rather than a short-term gain. Yeah. Well, I think that's very, very insightful and great advice that you've been giving to our listeners. I'd love to connect with you again in about 6 months' time to see how things are panning out for you. So, obviously it's a good time just sort of to finish on personally. How have you found this more time at home business going with you and your family?
Well, look, it's been good. It's at our cast of my grandchildren, so that's the only issue. But we do FaceTime a lot, I guess. And if they start lifting restrictions this week, the Victorian government, then we'll know more about whether I can see them. But the personal time has been terrific. I've cut down to basically a 3.5 day week. Today is I don't usually have Mondays off, but I've taken Mondays off.
Lucky me.
Because the practice without the non-essential stuff is only a 3.5 day practice. It's not a 5 day practice, even in a mature practice like us. And once you start carving out all the stuff that can be done by telehealth or done at another time, it does diminish the time you need to spend on the ground, which has been lovely. I've very much enjoyed my long weekends, and maybe at my age I should be doing it more often. But it has given me a taste of life. It has allowed me to do other things. We're doing I'm just, as I was saying to you off air before, that we're just finishing off a COVID-19 brief report on injectables that's going to be submitted to the Australasian Journal of Dermatology, because the article we finished and was published in March with Stephen Luce, Sarah Hart, and Peter Cullen, and myself, is already obsolete, and we needed to refresh that in the days of COVID. So we've had ourselves, and we've also had Isolde Hardenreich from South Africa, and John Sullivan and Naveen Samir, who's head of ASIPS, contributed to a revision of those things. So that's allowed me all that sort of academic stuff that I can do in my spare time, which has been terrific, and has meant that I'm not trying to crowd that on top of my normal working day, which is good. So it's so from that point of view, it's been good. Yeah, it's been an enjoyable time.
It's fantastic, and it's great that you've been able to sort of invest a bit of time in that. And it's interesting times, this COVID, definitely. All right, Greg. Well, I might finish up there, and thank you for your time, and keep up the good work. I just your knowledge and constant improvement into this area is so admirable, and it's just great to be able to sort of have a chat with you and see where we're going. And if we can catch up in about 6 months, there'll be a different time, as you said. Even with that report, within a week it's out of date, so who knows what's going to be happening. And
Yes, and another week it'll be out of date again.
Yeah. All right, Greg.
Okay.
So
Thanks, Hanya.
thank you for your time. I'm going to finish the interview there, but before I stop recording, I'm going to take a screenshot of you and I. So when we post it on Instagram and so forth. So get ready so I'm on the Mac and I've just got it in gallery view.
Yeah.
And I'm just going to do a little screenshot. So here we go. 1, 2, 3. Done. Lovely. So the episode will come out in the next week or so. So I'll let you know. Thank you so much for your time.
Pleasure. Thanks, Hanya. Enjoy the rest of Monday.
Thanks, Greg, and we'll talk soon.
Okay. Bye now.
Ciao.